Psychiatry, so I guess I'm a senior trainee now. I don't have a particular interest in this topic, but I was just kind of asked to talk on this, and the slides have actually been pre-prepared, so I'm going to talk to them, but I'm really happy to talk about other stuff that's come up as well, or if you're unclear of anything, I'll try and answer as best I can. So what I understand is that we're going to talk, I'll talk through these slides and it will take up to an hour. It probably won't take an hour, but we can see how we go. And then I've been told that you guys have got cases to present after that to talk about. Is that what you guys understand? So look, basically the thrust of what this presentation is about interactions between medicine and psychiatry, but part of that is going to be around psychiatric emergencies as well. So we can talk through the kind of stuff that comes up there. So I guess this is kind of broadly the different areas in which it interacts. With regard to the first point, so psychological complications of a medical disorder, that's a really common thing that you'll see in consult liaison particularly. It doesn't sound like you guys are on consult liaison, but certainly if you're going to be doing GP or a medical specialty or surgical specialty, it's really important to be aware of the kind of things that can look like psychiatric disorders, but are actually kind of organic in nature. Does anyone know of any particular causes for say, anything that might mimic a depression?
Thyroid disorders?
Yep, that's right. So thyroid disorders is a really common one. Obviously, hypothyroidism are more likely to get depression, and hypo are more likely to be kind of anxious, but you can get a bit of both. There's a really long list of stuff, but things like Addison's disease or carcinomas or multiple sclerosis has really high rates of mood disorder associated with it. What about psychoses? Anything that might make people appear psychotic?
Drug use?
Yep.
Substances? Like meth?
Yep, that's right. So we'll talk more about substances shortly, but you can either have you can have someone who is under the acute influence of a substance. So say if someone takes a hallucinogenic drug and they're they could be hallucinating, but it could be the actual active effects of the substance. You can also get like drug-induced psychoses. So someone might take, say, methamphetamine, and it might be, amphetamine usually gets out of your system within 24 hours, but you may have a lingering psychosis for weeks to months, irrespective of that. Anything else that comes to mind for people?
I have something, but it's more of a question.
Yeah, sure.
Is paroxetine, you know how if you're at a certain dose, like taking 80 milligrams a day, like 40 milligrams BD, and that's what's been prescribed, but the patient's been, say, not very adherent to treatment and has just taken it, like not taken it for a couple of days and then gone back to taking more, that sort of thing, is without sort of gradual tapering. Would that lead to a presentation similar to psychosis?
It shouldn't usually lead to psychosis. So paroxetine, as compared to other SSRIs, it's got a very short half-life, and so you tend to get more pronounced withdrawal effects. But the withdrawal effects are usually not psychotic. It's usually stuff like just feeling really flat, feeling cold and fluish. They talk about kind of brain zaps where people get these funny twitches. They feel like their head's spinning suddenly. So usually the withdrawal shouldn't cause you psychosis. In terms of starting abruptly again, it kind of depends whether they gave it time for their body to adjust to baseline or not before they started back on the high dose. Even if they did start back at the high dose when they weren't ready for it, you could get a psychosis, but it'd be uncommon in someone who's not already predisposed to that kind of thing. You could certainly precipitate a mania with psychosis, but yeah, it'd be unusual, unless you've actually precipitated a serotonin syndrome, I guess. Do you guys know about serotonin syndrome?
I think NMS came up in the exams, not serotonin syndrome. It was like rigidity is like seen in NMS or serotonin syndrome. Yeah.
Yeah. So the trick, a great thing about those syndromes is you only really have to remember one. Does anyone have a mnemonic for it? Has anyone heard FARM before? So FARM's mnemonic to remember neuroleptic malignant syndrome, and it's fever, autonomic instability, so heart rate and blood pressure going up and down, rigidity, like you say, and then mental status changes, which is really means confusion or like disorientation, that kind of thing. And that same mnemonic applies to serotonin syndrome, except you don't tend to get rigidity so much. You tend to get kind of tremulousness and hyperreflexivity, and kind of increased tonicity. Sorry, but not like not like a increased like lead pipe kind of tone increase, but more of like a spastic increased response to either trying to get reflexes or listening clonus or something like that. The other things that might be different, you tend to get more GI upset in serotonin, and you tends not to be such a problem in neuroleptic malignant syndrome. You tend to get higher CK rise in NMS. What else is different? But otherwise they do present quite similarly. And the other key thing will be in the history, like have they had a ramp up in antipsychotic or a ramp up in serotonin? Are you guys, just broadly speaking, have you heard about the ideas of NMS and serotonin syndrome before? Yeah. So NMS just basically being it's not quite clear what causes it, but it's associated with sudden starting or increasing in dose of antipsychotics, and serotonin syndrome associated with usually with multiple serotonergic agents, or to be honest, the only time I see serotonin syndrome is when someone's taken an overdose of it, really, of an SSRI, or sometimes you get it if someone's been started on tramadol or something like that. Do you guys know about tramadol and its serotonergic kind of properties? It's a funny one, tramadol, because it's classed as an opiate, but actually it has quite a lot of. So it's like it's a prodrug. So tramadol, you get like a racemic mixture of plus and minus tramadol, and they mainly increase serotonin and noradrenaline, and it has to get metabolized to go through to it's -0 desmethyl tramadol or something like that, and that has opioid kind of properties, but that enzyme is the same one that someone's responsible for converting codeine to morphine, CYP2D6, and a lot of the antidepressants block that enzyme or inhibit that enzyme. So if you have someone on an antidepressant and tramadol, you tend to get you're getting the increase in serotonin like you normally would, but also you're stopping it from being metabolized, so it's staying at the step where it increases serotonin. So the crux of it is try to avoid using it if you've got someone on an antidepressant. Okay. Any other questions around that? Around NMS or serotonin syndrome? Do you know what you do if someone has one of those things?
Of the medication that they're taking?
Yeah, that's exactly right. That's the main thing to do, basically. So there's a mnemonic that I can't remember, but it's S's. So it's like stop the medication, supportive care. So these people can get really sick, like they can end up in ICU, needing IV fluids or kind of pressors, or trying to bring down their temperature and that kind of thing. So they may need to be admitted medically or to ICU. You also want to kind of those are the main two. They'd be the mainstay. So thinking about supportive care. One of the other S's is the setting. So that's just thinking about, you know, does this person actually need to come in? And the other S is there are specific agents you can use, but you wouldn't be expected to know that. And I can hardly remember that myself. I think for NMS it's bromocriptine, and for serotonin syndrome it's something heptadine or something like that. But you wouldn't be expected to kind of get involved in that. So it's mainly stopping the agent and keeping an eye on them.
Are those drugs you mentioned serotonin antagonists?
Yeah, so bromocriptine is a dopamine agonist, D2 agonist, I think. So it's basically reversing the blockade from the that you get from an antipsychotic. And yeah, the other one is serotonin agonist, antagonist rather, but I can't think what it's called. Sorry. But they would use like. That's the kind of thing you might use in ED or ICU. You wouldn't really, if you're at a stage where someone's that unstable, you wouldn't be managing them as a GP anyway. And there are pathways for when to use it that the ED guys use. Okay. Physical and psychiatric disorder occurring at the same time. I guess that's getting at the idea that sometimes we have this kind of this thing like this Occam's razor, like come to one diagnosis type thing, but often it can be a bit of both. Like say with epilepsy and non-epileptic seizures, the rates of epilepsy in people that get non-epileptic seizures are actually higher than the baseline population. So just because you kind of diagnose one doesn't exclude the other. Likewise, maybe they have a problem with their thyroid, but maybe they actually are depressed as well. And in those cases, you treat the physical condition first. But yeah, it's just to kind of keep an open mind as to there might be both going on. We'll talk about deliberate self-harm, substance use disorders, and eating disorders a bit more in detail in a sec. And we're going to talk about medically unexplained symptoms as well. Do you guys know much about kind of cognitive impairment associated with medical conditions? I guess there's a few kind of broad areas. Anyone think of when that might happen?
Strokes.
Yeah. I was just wondering if you were referring to like dementia type of thing, or I wasn't sure.
Yep. So, as I say, I didn't write the slides. Your guess is kind of as good as mine. But yeah, I was thinking things like strokes is common. Yep, and dementias and the acuter version of dementias.
Delirium.
Yep. And the other, I guess, big one I was thinking about is like a traumatic brain injury. Have you guys? Are you guys kind of done to death with the difference between delirium and dementia? Have you kind of gone over that recurrently in the last few months? I guess I'm wondering, do you have any questions about that, or is that just kind of pretty clear in your mind? You've heard of those conditions, dementia and delirium? Sorry.
Yeah.
Okay, well, look, just really quickly talk to it. I mean, you guys probably know, but there's dementias are kind of a chronic process, and there's various different subtypes which look different, but are often mixed anyway. Can anyone rattle off the dementia subtypes?
Like frontotemporal Alzheimer's, Lewy body.
Yep. Great. So I think the other ones to think about are vascular. You can get like an alcoholic dementia. there's actually heaps of like subtypes of dementias, but it's like subtypes. Like there's like 3 different kinds of frontotemporal and, you know, a few different random ones of Alzheimer's and that kind of stuff, but it's probably not worth knowing. I guess the important thing about that is just remembering the different kind of ways they present. So vascular, they have more vascular risk factors. They tend to present in a stepwise worsening fashion. Lewy body dementia, you tend to get hallucinations, so particularly visual hallucinations, which is quite uncommon in other conditions. Lewy body dementia also, you get a fluctuating of kind of impairment, so they can look like a delirium. What else? And and Lewy body, obviously it's associated with all the Parkinsonism type stuff. So a lot of people that start with Lewy body dementia end up with Parkinsonism, and a lot of people that start with kind of Parkinson's disease end up with Lewy body dementia as well. Yeah, okay. Have you guys had much to do with traumatic brain injuries? It's kind of something you don't see a lot of often.
Not really.
No. Does anyone know what kind of stuff you see with a traumatic brain injury? Like a diffuse kind of axonal injury? No. They so obviously, like, traumatic brain injury is really variable. If you have a very clear focal damage, then it'll depend on whatever the brain that was damaged. But if it's something like a whiplash thing where it's just like diffuse sharing of axons, it tends to share predominantly in the long pathways, and one of the big long pathways is like obviously running to the frontal lobes. So you tend to get disproportionately affected frontal lobe function, and so you often find that people are really, so one of the big things the frontal lobe does, I can't remember how much you guys have done this, but one of the big things the frontal lobe does is inhibits responses. So it tells you not to do something. So people are quite disinhibited. They'll blurt things out, not mean to, they'll interrupt people, they'll make impulsive decisions. Also, their memory is often very significantly affected. The temporal lobes also get quite damaged because they're quite peripheral. And so you get quite a significant impairment in particularly short-term memory, and often a lot of like irritability and lability as well. And one of the things that you can see, which is which can look like psychosis, which can kind of mimic it, is when people have very bad memory, they may sound like they're paranoid. They may be paranoid, but they may just sound like they're paranoid and say things like, someone's been breaking into my house and moving my stuff, or someone's been altering my, he's broken into my bank account and is taking my money. And it's kind of, sometimes it's actually just based around the idea that they can't remember that they've done things. So they've moved their own cup, and then they've said, I didn't move that cup, who's moved that cup? So it's actually, it's kind of different, because it's not that their ability to kind of rationalize logically is impaired, but they're just getting faulty information in. And so it's kind of like a reasonable conclusion to come to if you think that cup actually did move. And unfortunately, with a lot of those things like traumatic brain injury, stroke, and psychosis, they just have really impaired insight. And so it can be really difficult to explain, no, actually you moved that yourself. Okay, well, should we talk, any questions around that stuff, or should we talk through the deliberate self-harm and the substance use and the eating disorder stuff?
Just a quick question on what you said about diffuse axonal injury. Would that show up on an MRI?
I think you can sometimes see it in MRI, but I don't quote me on this, neurologists might know better, but I don't think you necessarily do if it's at a level that's, because like an MRI is, you know, like it's a very good scan, but it won't show like a axon by axon type thing. I think you can get kind of diffuse petechial hemorrhages that you might see, but I think you can also have a normal scan and still have damage.
Right. Now, we had a patient, like she presented with acute psychosis sort of type of presentation, but she's had quite a history of abuse with like trauma to the head and that sort of thing. And she's had an MRI contrast MRI in the past and stuff, but that's always been normal. So we were kind of sort of stumped for as to what was happening, because she's had a bad history of eating disorder as well, which is a very complex case. And I just wondered if this could be like a causal factor, but yeah.
Yeah, difficult to say. Yeah, those cases, they're really tricky because there's a whole lot of things that might contribute, including the eating disorder part of it, which we can talk about shortly. My understanding, it's not something that I'm like very well versed in at all, but my understanding is that generally when you're talking about traumatic brain injury, you're mainly looking at functional assessment and cognitive assessment, not so much neuroimaging, although it's obviously helpful if it shows stuff. But yeah, so I guess the answer is I'm not quite sure if you can rule it out based on the fact that the imaging was fine, but the neurologists would probably know that more. Anything else? Oh, cool. All right. Well, look, psychiatric emergencies is obviously a lot of it is around self-harm and suicidality and that type of thing. So the first thing to think about is from our point of view, we'll be asked to see people who may or may not be medically cleared yet. And so that can mean a few things. So it could mean that they've done something and it's not clear yet as to how dangerous that is. So often if someone's taken a overdose, then they need a period of assessment or a period of kind of observation before you can determine whether they're actually unstable. The classic one is paracetamol overdose, because you have to take like I'm not sure you guys see much of that, but you have to take a level 4 hours after the dose was taken to kind of standardize it as to whether they need an N-acetylcysteine infusion or not. And so often someone comes in within that 4-hour period and you don't actually know. The biggest problem that you also get is if someone is taken something or done something to themselves, which means that they are not able to give you a complete or accurate history or engage in the interview properly. So commonly it's going to be either they're intoxicated with usually alcohol, or they've taken an overdose of something sedative, an antipsychotic or a benzo or something like that. It's really important that you don't do a formal risk assessment if someone is impaired by something, because basically you're just not getting good information. Like really common that people present when they are intoxicated saying they're going to kill themselves, and once they've sobered up they no longer feel that way. So you don't, and it's kind of not fair to people to do that either. So if you think about, like, if you got really drunk and had a terrible night and ended up saying something that you like don't really believe during the waking hours, and then you woke up and you were admitted under the Mental Health Act to a psych ward, you'd probably be pretty miffed about that. And likewise, you don't know as well, like, if someone's underreporting things, like if actually things are really bad, but they're feeling okay because they've got a substance on board at the moment that's kind of masking things. As well as that, alcohol particularly is associated with increased risk of suicide. So you wouldn't really want to make a risk management plan with someone who's still drunk, because one of the big standout factors that's going to be increasing their risk is the fact that they're drunk. So if they're drunk and they've come in because they're suicidal, you really want part of the plan to be that they sober up. So usually they'll wait in ED until they're sober enough. But you might, we come into trouble because if the police pick someone up, it's they hold them under something called a 109, which is part of the Mental Health Act, which means you've got 6 hours to assess them, but some people take more than 6 hours to sober up, so it turns into a real situation. Okay, Regarding risk assessment, otherwise though, have you guys heard these things like static, dynamic, and protective factors? No. Well, look, this is how basically most people would do it. It's kind of just a framework to work with. I guess the thing to say is that no one's ever completely safe. Like you can never 100% say that someone's not going to kill themselves or do whatever it is that you're worried they're going to do. But having said that, you want to think about a few things. You want to think about, have you considered the things that increase their risk, and have you tried to mitigate those things? So this is kind of useful in both framing your decision making, but also in documenting that you've thought about these things. So basically, static factors are factors that are not changeable, things that have happened in the past or that are not amenable to change. So so things like being male gender, Maori ethnicity, previous suicide attempts, a trauma history, things that increase their risk, but you can't do anything about, basically. Then the dynamic factors are things that increase their risk but are changeable. So things like, are they currently depressed? They're currently psychotic? They're currently manic? What kind of psychosocial stresses are going on for them? Is there currently abuse or anything like that? Are they currently using substances? So those are things that increase their risk and you could do something about, or at least try and do something about. And then protective factors are things like, so ideally it's what they say. So you usually say to someone, hey, like, what are the things that stop you from ending your life, or what are the things that make you want to still be alive? And you're trying to elicit things like, family, friends, I want to get better, I want to get through this kind of thing. Once you've kind of done that assessment or got those factors out, then you kind of want to think about a risk plan, because an assessment by itself is pretty arbitrary. Like all you're going to do is write down some factors, and you're probably going to come to the conclusion that the risk of completed suicide is higher than the baseline population, but less than 100%. And so you kind of want to frame your decision around how likely you think they are to end their life and what you might be able to do to change it. So the kind of things you think about in terms of the risk, the big thing is like the most important predictor is what have they done before to end their life. And particularly that's important if the reason you're seeing them is because they've done something to end their life. So you'd be thinking you really want to understand what their attempt was about. So did they research it? Did they make any preparations for not being alive? So making a will, like that would be really worrying if someone had completed a will, or that kind of thing. Did they write a letter? If they sold their possessions, and then what was their understanding of the lethality of what they did? Well, firstly, how lethal was it? And how long had they been planning that? How much consistent effort went into planning it? How likely do you think did they think it was that they'd be found? Did they reach out for help or not? And you kind of, when you go through in like real detail, you kind of get a bit of a sense about like, was this someone who took a overdose of something that they probably didn't think would kill them and sought help? Or was this someone who did something that they thought would kill them and didn't seek help? And that really shifts kind of how worried you are about them. And then you think about, well, what are the things that we can change? So if the home environment is just unsuitable, like there's not sufficient supports, there's not people that can keep an eye on them, then that might lead you to think about maybe admission to the ward or admission to respite. If it's something like, maybe they've got a depression, then it's going to lead you to think about treating that depression. And if it's something like substance use, then treating the substance use. So really just trying to pick apart like what like, I know this person is at increased risk, but what can I do to, what's reasonable to do, and what can I do to reduce that risk? And if you do that, you've kind of done your job. But yeah, you do have to acknowledge that you can never kind of completely mitigate it. I mean, there are suicides that happen on the inpatient units as well. So, you know, it's can never kind of completely rule out. Any questions around that area? Because I know that's like a big topic in itself, risk assessment.
We have a patient like who came in yesterday who'd like deliberately self-harmed. Would you like me to like do a short history on him, or?
Yeah, sure.
It was like he's a 21-year-old Caucasian male who self-presented to the ED yesterday, after he'd attempted to take his life. So it was more of a he had a shotgun that he lives on a farm. He fired off a shot to see if it worked, and then when he tried to reload it a second time to kill himself, he just couldn't get himself to do that, and so he just ran and told his parents and then presented yesterday. I saw him this morning. He is severely depressed. I guess he has a supportive family, and I think he knew it was a lethal method, but it was more of a calling out for help as opposed to him wanting to kill himself.
Yeah. So that's a really good case to discuss. So he's admitted to the inpatient unit, is that right?
Yeah, so that was a crisis call yesterday, and he's an inpatient today.
Yeah, no, I definitely would have admitted that guy too. So so the thing about that is, even though he reached out for help, there was a lot of preparation for a very potentially high lethality attempt. So things like hanging and use of firearms are way more likely to kill you than an overdose of something. Obviously, it depends what you take, but it would be different. Like so say a lower risk situation might have been he's thought about ending his life, and he's thought about shooting himself, but he doesn't have access to a gun and has never gone through with any kind of rehearsals. But it sounds like he did have access, and he's depressed, and he kind of, one other thing to look out for is if people building themselves up like that. So kind of going through the motions, getting ready to end their life. You don't want that, like things like people going up to, say, a rooftop. That's very worrying. Like people getting the rope ready and that kind of stuff. Anything that kind of is potentially very high lethality, and there's a sense that it's building. Because that's the other thing to say about risk is sometimes it's like if he said I got the gun out to think about shooting myself, but I do that every day and have done for the last 10 years, you probably would say, oh, okay, well, that's not, maybe that's not so worrying, but actually it's not like he does this all the time. So so you could say that like his risk at that point was possibly the highest it's ever been, and you don't, given that it's not stable, you don't know at this stage whether it's going to increase or decrease. So you've kind of wrapped around it a bit and said, okay, well, we're going to bring you in to an environment we know is safer. And especially if there's a severe, significant depression there, that's something that's very intervenable as well. So it's, yeah, I guess, does that make sense as to why they would admit him? Okay. Any other questions around suicidality? I'm sorry, I use that word, just means thoughts of ending your life, really.
Sorry, I was just wondering with the intoxication that you're talking about, not doing a risk assessment, if someone was to present to ED like acutely suicidal and they were intoxicated, what would you do if you didn't want to do a risk assessment or put them under mental health act, but they wanted to leave?
Yeah, that's a really good question. Yeah, so we can talk a bit about that because we don't have it. I don't have a slide for it, but do you guys, have you had much talk about the Mental Health Act and when you can use it and when you can't, or not really? A little bit. Okay. Well, look. Sorry, this is not as stuff you've covered before, but basically there are two limbs to the Mental Health Act. So you have to have an acute risk to yourself or other. When I say two limbs, like two things that you have to meet, two different checkboxes kind of thing. So you have to present a serious risk to yourself or others, or a significantly diminished capacity to care for yourself. That's one limb. So it's got to be something going on, and that impairment has got to be due to what's called a mental disorder, which is actually a legal term, and it's a disorder of mood, perception, so hallucinations, delusions, volition, or cognition. They're super weird terms because they're old and they're legal. They're not kind of new in clinical terms, but basically the important thing there is that you don't, you can't really weigh in on that. Like you can't really say whether you can't do a valid assessment to say whether they're depressed or not, or whether they're going to mental illness or not when they're under the acute influence of something else. So there are actually a bunch of other kind of frameworks to work with. So the really common one that would get used would be something called like duty of care, that like the ED guys would use. And that's got a variety of different kind of interpretations, I guess. So one of them is that that you can basically do most things if you're really worried about someone. Like if someone had a gun to their head and was about to shoot them, and you slapped the gun out of their hand, about to shoot themselves, and you slapped the gun out of their hands, you're not going to be done for assault for that because you've, acted in a way that was you trying to save their life. The other thing is that when people are intoxicated, you can often say that they don't really have capacity. So people, if someone's really intoxicated, you can just say, look, they don't really have a good understanding of what's going on for them right now, and they don't have capacity to make decisions. You don't have to go down like a triple PNR or an EPOA kind of route with capacity. There's a provision in the Health and Disciplinary Commissioners Code, section 7.4, that basically says you have a right to make decisions around your treatment, assuming you have capacity. And so basically this is the opposite of that, saying you're saying you're going to kill yourself, you're intoxicated, you don't really know what's going on here, we're going to stop you from leaving until we can do that assessment. So ED wouldn't, so I guess thinking from your point of view, if you're probably going to be an ED, I guess, say you're an ED, then yeah, you can just stop them under that. They usually, like locally, they'll just say under duty of care, not allowed to leave the department kind of thing. I guess generally the other thing to say about the Mental Health Act is that one of the, it's actually not that hard to meet criteria to put someone in the Mental Health Act. So the question you're usually asking is not, can we put them under the Mental Health Act, is should we put them under the Mental Health Act? And so that's really around thinking about like, is it like, do we need to do it because we're so worried about the risk, or do we think that it's in their best interest right now? Because the Mental Health Act kind of stipulates that you should try and use the least restrictive means. So like if someone, say, had some delusional thinking, and maybe there's a bit of risk there, but they were willing to engage with you and take medication and come to appointments, and you could make a safe plan, then actually probably say that the use of the Mental Health Act isn't appropriate, even though they might meet criteria for it, because you're able to kind of manage that in the community. Yeah, does that make sense? That you don't kind of have to use it if it comes up.
Yeah, thank you.
Cool. So one of the other big areas is thinking about substance use. We have time, basically blasted through the first hour. Poor. All right, straight off the bat, does anyone have any questions about substance misuse or substance use disorders. Can anyone give any ideas about what might make you think someone has a substance use disorder?
If they're like a known user and have been using for some time, and you suspect that they've taken it recently so that the drug can still be in the system, or just a reason to suggest that they have a drug in the system which is maybe proven via biochemical tests or otherwise, and it's just not attributable to any other organic causes, and they display symptoms to suggest that they're seeking that drug, and that's caused a significant decline in functionality, that sort of thing.
Yep. So that last point is particularly important. So I guess the thing is, like, you can use any of these substances. Not saying you should, but you could, and you wouldn't necessarily have a substance use disorder. So there's a few different criteria to think about when when think about someone does have a substance use disorder. Sorry. The DSM has like a long list of things. So you need 2 out of 11, and there's kind of all these different symptoms. 2 of the important ones are the biochemical ones, so tolerance and withdrawal. So have they developed a greater tolerance to the drug? Do they withdraw from the drug if they don't have it? But the other really big thing that you touched on is the decline in function. So to summarize most of the points, it's about primacy. The idea of primacy. I don't know if that word's familiar to anyone. It's basically the idea that the substance takes priority over an increasing amount of your life. So, so if I go out for drinks on a Friday night, and I'm okay, and it doesn't affect my life otherwise, and that's probably not a substance use disorder. But if I go out for drinks when I'm supposed to be, on call that night, and maybe I've got commitments the next morning that I don't go to because I'm hungover, and I rake up financial debt because I need the subs, I need to keep using, or I develop symptoms of like liver failure, but I keep using it anyway. It's all that stuff that really makes a substance use disorder. It's when it becomes more important to you than other things. So when it becomes, so primacy is kind of like this prioritize, like this is the top priority. It's about using the substance, and everything else comes second, whether it's your job or your finances or your relationships or your physical health. So one thing so the really important thing to think about if you're wondering about that is what cost it is to people. You can, for alcohol, you can use the CAGE questionnaire. You guys heard of that? Yep. So you, 2 out of 4 of someone trying to cut back, become annoyed at other people criticizing their drinking, feeling guilty about their drinking, or needing an eye opener, like a drink early in the morning to get going. I was going to talk a bit about specific substances, but maybe we'll just go through really quickly. Does anyone know what are the big concerns with alcohol use in the long term? What are the things that can go wrong medically?
I mean, like liver disease.
Yep. So liver disease is a big one. The other thing to think about is, and it's kind of related to the primacy thing, is around like malnutrition. So if they only have certain financial means and alcohol's expensive, then they may not be buying food. They may not be able to kind of stomach food because the stomach's so inflamed or whatever's going on. And certainly you can get liver failure down the track. So
I have a question. So someone told me today about refeeding syndrome being an issue sometimes in alcoholics. Can you talk a little bit about that?
Yeah, sure thing. So it's relevant for both alcoholics and eating disorders. And have people heard of refeeding syndrome? It's a little bit, yeah. So basically, I'm no expert, but there's a few. So when the body releases insulin, obviously it's the main function is for glucose to go into cells, right, to utilize blood sugar. So that's why when you're not producing it, the blood sugar just keeps going up because the cells aren't taking it in. But it also changes the flow of different electrolytes as well. So it causes phosphate to go into the cells, magnesium, and potassium. And if you have someone who is not eating, not taking sufficient calories in for a prolonged period of time, and then you'll hear the term refeeding syndrome most commonly when someone comes into hospital. And the concern there is that their body's going to react with significant kind of changes in their electrolytes when they eat food, and therefore have an increase in their insulin output, which can be obviously really dangerous. So you get this paradoxical thing where people can actually become, if you start feeding them with a bunch of carbohydrates, they become hypoglycemic because they're having a lot of insulin released in response to carbohydrate load, but they don't have the glycogen stores in their muscles or the liver to keep pace with it. So you have these funny situations sometimes where people have low blood sugar and you have to decrease their carbohydrate intake. But otherwise it's monitoring those other electrolytes. So it's kind of, so when people are refeeding, normally you have like a kind of, you make sure you're supplementing the things that they're likely to go down on, like phosphate and potassium, and you're monitoring them like regularly, usually daily if they're inpatient. I had a woman who had very severe, so she was, God, I was worried that she might die at once when I first saw her. So she was drinking 3 liters of wine per day. She was vomiting multiple times per day. She didn't really eat. I don't think she actually ate for like a few weeks. She was hallucinating, and she'd had seizures when she'd stopped drinking. So she was in a really bad way. So for her, we ended up admitting her to hospital, and one of the for a planned detox. And one of the things that was driving that was concern around refeeding syndrome, because her electrolytes were just all over the place. So her electrolytes were all over the place anyway, and we were concerned they were going to be even more all over the place. Does anyone know what we do in terms of the seizure side of things? So you guys know, like alcohol withdrawal, one of the big things is seizures. Do you know what we use for the treatment of that? So the main thing is diazepam. The seizure, so you can think about alcohol as being pretty similar to a benzodiazepine. So like a GABA agonist. So like a kind of a depressant, CNS depressant. And basically what happens with either prolonged use of alcohol or benzos is that those receptors stop kind of working the same. And so when you don't have the substance, you get this kind of excitotoxicity, which can lead to seizures. And alcohol comes out of your system really abruptly. So it's got that, what is it? It's a serial autokinetics, I think, is it alcohol? So, you get better by the hour, and and that's why people feel so hungover, because it suddenly goes out of their system. Whereas benzos don't, they go down slowly, and particularly diazepam goes down really slowly. So it's, if you take diazepam on Monday, you'll still be able to see it in someone's system in like a week later. And not only that, but the things that diazepam gets broken down to are also active benzos. So really, really long lasting. And so what we do is you can do it either as an outpatient or an inpatient, but you'd start someone on a CEWA scale. You guys heard of those or seen those? They stand for something. Basically, it's a scale that looks for signs of alcohol withdrawal. And if someone's in hospital, say, then every 4 hours the nurse will take the score they'll look for signs like are they shaky, anxious, sweating, agitated, nauseated, vomiting, and they will, depending on what they score, they'll give them some diazepam to offset the withdrawals. And that process will probably take usually it's somewhere between 3 to 5 days of diazepam tapered off. So they kind of basically, as the body readjusts, they go down the diazepam dose. Does anyone know about other serious issues with prolonged alcohol use?
Wernicke-Korsakoff syndrome?
Yeah, that's right. Do you know what that's due to?
Like thiamine deficiency, and like with prolonged use, it can lead to like confusion and confabulation.
Yep, that's exactly right. Yeah, so it's prolonged kind of thiamine deficiency, which is again related to people just not eating. So if I've got someone who's got a chronic alcohol use disorder, I'd usually just treat them with thiamine. Same with an eating disorder. Those are really important things to watch out for. The other thing to remember is not to give them like, if someone comes in and they're really not in a good way, really malnourished, it's important to replace thiamine before you start them on refeeding as well. So one of the things that, like, say you've got low thiamine levels, if you have a sudden spike in your sugar, you can actually precipitate even worse, even more pronounced low thiamine levels. Do people know about the kind of signs of Wernicke's and Korsakoff's? There's kind of, it's taking me back a bit, but Wernicke's is, you get that triad, so confusion, ataxia, and was it ophthalmoplegia, I think, basically like the eyes don't track all the way along. They get paralyzed kind of thing. So people will complain of like blurring when they look to the sides. And then with Korsakoff's, it's like a permanent change associated with the cognitive decline and confabulation and confusion. Am I missing anything there? I can't remember. I feel like there's 5 points to Korsakoff's. Who knows? How are you guys holding up? Do you need a breather? Do you want to like take 5-10 minutes to get a cup of tea or something? Are you happy to push through?
Maybe like a couple of minute break. I just need to grab some water.
Yeah, go for it. Let's say meet back at like 4:15. Take 5 minutes and.
Yeah, sounds good. Cool, thank you.
All right. Is everyone back? What's the time? Speak up now if you're not back. Well, I can see 5 of you. So look, let's just crack on. I'm aware that it's like the end of the day on a Monday as well, so I'll try and flip through fairly quickly. If there's anything that I'm talking about that you're like, this is really important, I want to know more about that, then we can ask, but otherwise we'll just kind of crack through. So look, obviously you can be addicted to these other substances and there are withdrawal syndromes associated with those. They're not generally as dangerous as the other ones. As a quick rule of thumb, the withdrawal syndrome usually looks like the opposite of what the intoxication looks like. So like a stimulant, say people will have more energy, more concentration, they'll have suppressed appetite. When they're in withdrawal, they'll be really tired, lethargic, they'll eat a whole lot of food. Yeah, so are there any questions around that stuff, or should we just move on? Look, eating disorders, I won't go into too much, but they're another kind of interface between mental health and physical health. So just to talk through the kind of things that can go wrong with your physical health, the big things are really so electrolyte derangements and the cardiac issues associated with those, which can be just due to them not eating, or can be refeeding syndrome, or it can be that they're abusing a laxative that's got something in it, or particularly bulimia is associated with more electrolyte derangements often, because they're actually vomiting up stuff that's not, they're not just vomiting up water, they're vomiting up the gastric contents. But you can have really wide-ranging stuff. So the thing that you see quite a bit is kind of tachycardia or bradycardia. Tend to see more tachycardia actually. I did 6 months in the eating disorder service, and you tend to see more tachycardia, and it's generally sitting to standing, and it's often doesn't really matter, but it's kind of something that you see a lot of. The kind of other issues you might see are things like osteoporosis, so loss of bone density. What other kind of things? Loss of kind of your menstrual cycle, impairments in your fertility. There's a whole long list that you could look at. I guess the big thing that I wanted to touch on is thinking about the fact that the physical state can also affect your brain as well. So has anyone talked to anyone who's like starving before? It's a funny thing, but they get this like change in their cognition where they tend to be very rigid and concrete, not able to think about the long term or abstract concepts. So part of the thing that happens when you have a severe eating disorder, or the first thing that we want to do with someone who's underweight with an eating disorder is restore their weight to like a reasonable BMI, so, and that'll vary from person to person. But if someone's really low weight, then that thinking becomes very entrenched and hard to shift. But once you restore some of the weight, you'll actually often see a softening of those thoughts, and you'll often see people kind of really, because when people are really starved, they're really they appear very flat and kind of unemotional often, and really difficult to engage with. So just thinking about if you are in that situation, one of the things as well that can happen is that people actually get misdiagnosed with personality disorders when they're in a state of starvation because of how difficult they can be. It's like, I'm sure you've all got really stubborn friends or people that are really stubborn, but it's like talking to someone and it's just like, and they're like, no, because of this. And you're like, okay, but what about this? And they're like, no, I'm not eating, and it's just like very, you're not gonna get anything from it. So just to touch on it really quickly, there's a few different things that happen when people have severe eating disorders. So there's something called CREDS, which is the Central Regional Eating Disorder Service, which is based in Johnsonville. And they manage people in the outpatient setting, and they've also got about 6 beds for residents and about 6 beds for day patients as well, so people that come in. And they do a few things there. One of the big things they do is meal support. So basically, if they're a resident, they're doing other, they're stopping them doing other stuff like excessive exercise and that kind of thing. But actually, it's really hard for people with eating disorders to eat generally, assuming they have anorexia. And so it's kind of supporting people through that, getting them used to eating, kind of supporting the distress that comes with the gain of weight. They do a lot of groups around kind of anxiety and mood management and that kind of thing. So if someone's at a stable BMI, they can be managed in the community with kind of therapy. If someone, and dietitian input, that kind of thing. If someone is, say, between BMI 14 to, or I don't know, I mean, it varies, but down to BMI 14 and has other risk factors, then they could be managed as a resident in the program at CREDS. But if they're below BMI 14, CREDS won't take them because they don't have 24-hour nursing staff or 24-hour medical staff. So they'd need to look at either admission to a psychiatric unit or to an inpatient unit. And there's various different cutoffs, but often it's BMI under 14 goes to a psych unit, BMI under 12 goes to a medical unit. but in practice it often goes medical anyway, because they might need things that the psych unit can't provide. And the big things would be, the big thing would be parenteral feeding, so insertion of an NG tube. And you can actually, so you can use an NG tube involuntarily. So obviously you don't want to do that. You ideally want people to eat of their own accord. And if they're not going to eat, then you want them to accept the NG tube. But if they're not going to accept it, you can actually put it in. And you can either do that under a duty of care thing, saying that, or saying that they don't have capacity at the moment because their cognition is so impaired that due to the starvation state, or you can actually do it under the Mental Health Act. It's one of the few. So I didn't say this before, but you can't use the Mental Health Act to enforce treatment for physical conditions. So in this case, you can use an NG tube because you're treating the consequences of a psychiatric condition, but you couldn't use the Mental Health Act to get someone to take their blood pressure tablets or that kind of thing. Any questions on eating disorders? I mean, obviously it's a whole thing in itself, but yeah. So this is something called medically unexplained symptoms. Have you guys heard of these terms before?
Yeah.
Yeah. How well do you know them?
Not that well.
Well, sure. Look, we'll talk through them maybe just really briefly again. So malingering is not actually really a diagnosis, like it's not in the DSM, but it's kind of accepted term, and it basically means that you are deliberately, consciously misleading people regarding your kind of physical state, so or mental state for that matter, actually. But so things like, you know, and we'll talk, and factitious disorder is the same thing in regard to that. So it's you consciously misleading people, but the difference between them is what kind of gain you get out of them. So for malingering, it's something called secondary gain. You'll hear that talked about a bit, about the secondary gain, and that means like secondary kind of refers to external to you. So factitious disorder, you get primary gain, and so primary gain is like so I felt guilty that I haven't been studying. But if I say that I'm sick, then I'll have a sense of relief from that. So it's kind of like, it's not a very good example, but or say a shift into a sick role kind of thing that's not to do with like finances and that kind of thing. Whereas malingering is like so factitious is kind of like you want people to be nice to you, treat you like you're unwell, that kind of thing. Whereas malingering is like, I want to get off work, I want to get ACC when I'm not actually injured, that kind of thing. So it's kind of like obviously frowned upon in the medical world, malingering. Does that make sense, those two? Like it's basically falsification of symptoms, and the difference is whether it's to get kind of love and care and support, or whether it's to get kind of finances and you know, financial assistance, or get off doing work or whatever it is.
So I was just wondering, in both of them, are you aware that you're making up the symptoms, or do you actually experience the symptoms but with no physical cause?
So both of them you're aware. That's the difference. So that difference differentiates them between the bottom two disorders. So so in illness anxiety disorder, it was previously called hypochondriasis. In that one you have a preoccupation with the idea that you've got an illness, and you do think you've got the illness. So it's like, I think I've got cancer, you know, kind of thing. In somatic symptom disorder, and it's kind of in the name, but so that's about illness. Somatic symptom disorder is about you have got a symptom that is kind of not medically explainable, but you do genuinely experience that symptom. So a lot of things like, a lot of things might fall into this. So a lot of like kind of pain issues. We'll go into them next, but we may as well go into them right now, in fact. But a lot of these things would be kind of considered under that umbrella. It's a little bit tricky because the the diagnostic frameworks are not like unanimous. So like irritable bowel, I've called it notable bowel syndrome. I don't know. I assume that's just irritable bowel syndrome. A lot of these things are not. They're not in the DSM. I presume they're in the ICD because they cover non-psychiatric diseases as well. But there's a lot of different people that are dividing up these things differently. But these are they're really common presentations with symptoms that don't have medical causes. And specifically, it's really common that's genuine, that actually they do have these symptoms. And you have to be, so in terms of when you're dealing with someone who's got this kind of stuff, you have to be really careful to validate that they are experiencing that. Have you guys heard the term validation? If not, it's like probably the most clutch thing. Like it'll save you in so many situations. But basically, when people are upset about something, really most of the time they want to be validated. So they want to hear that it's reasonable to be feeling the way they're feeling. So if someone comes in and says, it's like, so someone comes in and says, I've lost my job, or something like that. The knee-jerk response that everyone would have would be to say, oh, look, things will be fine. You'll get back on your feet. It's not that bad, kind of thing. But the problem with that is it can be perceived as quite invalidating. And so often what people really want to hear is, oh man, that sucks. Like that's really horrible that you lost your job. Like it must be really hard to go through that. Which is kind of counterintuitive, but it really does work wonders. And so when people are have these symptoms, it's really important that you validate that, that we do, we know that you are experiencing these symptoms, and that they are real symptoms, you are really feeling them, but that, the tests have not shown have not shown a diagnosable condition that can be that can be treated. So what we want to do is shift a focus to kind of like living with those symptoms, and in doing so, we're gonna hope that we're gonna improve those, because a lot of these things don't have really clear like treatments, or sorry, I should say, like they don't have any they don't have cures, but I think it's in the next slide. But yeah, so CBT has been shown to be really effective for a lot of these. I guess if you think about like when someone's got these, when someone's got like say a problem with pain, you want to think about like obviously them living with the pain, and accepting the pain and minimizing disability associated with that. So say for example, someone's got pain and they think, oh, I've got this pain, I'll never be able to do this again, that again. You can actually address those thoughts because often they're out of whack, they're quite catastrophic, and they're not true. It's a different kind of therapy, but ACT is another way of approaching it, and it's kind of similar. And it's basically just doing things despite your symptoms, like living the life you want to live despite your symptoms, not letting them kind of dictate the way you live your life. And the other thing to think about is that you want to address anything that is actually treatable by itself. So often these things are comorbid. So someone might have chronic pain, but they might actually also be depressed. So you want to treat the depression with CBT or an antidepressant. You want to manage sleep. So sleep is a really important modulator of pain. If you're sleep deprived, you're going to feel pain worse. And then vice versa. And you want to make sure that you're managing anxiety and stress levels, because they also kind of modulate pain. Likewise, if someone has an anxiety problem, you want to manage pain and sleep. if someone has a sleep problem, you want to manage anxiety and pain. You kind of want to make sure that you're kind of holistically tackling things, not just attacking the thing that's in front of you as a presenting complaint. Right. So I know I kind of really barreled through that last section in the interest of time. Any questions around that or any cases that have come up?
I just have a quick question on the previous slide. Would Munchausen syndrome be considered fictitious or malingering?
Yeah, it would. It's fictitious, Munchausen syndrome. So that's been rebranded. In psychiatry, basically, a term comes up, and then if it gets used for a few years, people start using it in a derogatory way, and so it gets a name change. Well, that's in medicine anyway, across board. So, you know, like all those things, like there's that list, but cretin and idiot and all those stuff. They used to be medical diagnoses, but they got a bad rap, so they came up with. Well, actually, it keeps changing now. Like, it was intellectual disability when I went through, but I've got a feeling it's now learning disability. But I don't know. Yeah. So yeah, but fictitious disorder. Any other questions?
I had a question just about eating disorder.
Yep.
If someone has eating disorder, and like, so there's this lady who's the one I talked about at the beginning who presented with sort of psychosis, but there is a past history of anorexia nervosa, which she doesn't think it was a problem when she was little, but she's had heavy like alcohol use and smoking history and meth use as well. So we thought, so when I was at the crisis call, I thought she had substance-induced psychosis. But like when talking to her afterwards, it seems I was trying to gauge whether she has like still that eating disorder picture, like underlying sort of grumbling along over time. Because when she was admitted, she was like 38 kgs, and she's 42.
Yeah. Okay,
yeah, 38, and she's like 165 centimeters. So I haven't calculated her BMI just yet, but it's pretty low. But the thing is, she still eats, like she just loves eating chocolate. And when I went to see her, she was drinking Fortisip and eating chocolate and like all these lollies that her stepdad not sneaked her, but got her. And like she lost quite a bit of weight. She's not happy with how she looks because she weighed 48. Yeah, she weighed 48 kilos beforehand, before she kind of her condition.
When you say before her condition, do you mean before her eating disorder, before her cycle?
So like, so she, like a couple of, I think a month ago, she weighed 48 kgs and she was sort of happy with that. And then when she presented last week, she was 38 and she wasn't happy with how she looked, in the sense that she looked really scrawny and that she'd lost a lot of weight, and she wasn't happy with that. She wanted to get back to her original weight. I think it was more meth-induced weight loss, but the fact that she's happy to eat and all that stuff, it doesn't paint a picture of someone with eating disorder, right? I mean, I know she had like lost a lot of weight and everything over time, but couldn't that be due to meth-induced sort of lack of appetite with her increasing use over the past months?
Yeah, it certainly could be. I mean, it's a bit speculative without knowing the patient, but people can have a history of an eating disorder and they can be in remission. And often they can retain a kind of remission, kind of maintain remission. But it's not uncommon that they'd have a vulnerability to kind of relapsing into eating disordered behaviours. And one of the things that we see a lot in eating disorders, but also in psychosis, is something called ambivalence, which is a term that gets used a lot, but often incorrectly, I think. So it doesn't mean that you're unsure, you're on the fence. It means that you hold two contradictory views to be true. So it's not uncommon that someone with an eating disorder would acknowledge that they're underweight and want to gain weight, but also want to lose weight and feel that they're too, like they may hold this kind of strange state where they know that it's not viable to lose weight, but will want to continue to lose it anyway. The other thing to think about is that it's not uncommon for people to develop an eating disorder. So there's a kind of interplay between eating disorders and organic weight loss. So if people have, say someone loses weight because they have got gastroenteritis when they're 15 and have not previously had an eating disorder, sometimes people get like almost an eating disorder induced by that weight loss. They struggle to put on that weight again. They did this study when they initially were trying to work out people with eating disorders, and they starved a bunch of men, and the men felt so good in their starved state that they swore that people were putting something in their food that was making them feel good, that they're being drugged. And a lot of them went on to develop eating disorders. And so there's this weird thing where it's almost like, it almost looks like an addiction in a way. It's like, and being low weight is almost like exposure to the substance. And one of the things they think, so people do talk about feeling really good when they're starving. Like they'll talk about their anxiety's better, their mood's better. I don't know if any of you are subscribed to the new ketogenic kind of thing, but a lot of people, I don't think it's got a good basis behind it, but they'll say they feel great and they feel like cognitively savvy and their mood stable and all this kind of thing. One of the things they think might be happening there is that if you imagine someone in a state of, like normally, say an animal in a state of starvation, what you don't want is for that animal to, like, from an evolutionary point of view, you don't want the animal to curl up in a ball and give up and die. So there's a thought that maybe being in a state of starvation causes the brain to release something that makes people feel good for a last ditch attempt at kind of catching food, basically. And so it might be that what they're doing is kind of exploiting that in a way, like obviously in a very unhelpful way, in a very damaging way, but it's possible that they've got this kind of addiction to that kind of response. But sorry, that's a bit of a tangential answer to your question, but I guess what I'm trying to say is it's really complicated, really difficult to know. I suspect that she's still got a vulnerability to it, to losing the weight. Those kind of things like lollies and chocolate are a bit of a, it's a bit showy. Like it's not uncommon for people with eating disorders to be seen to eat lollies and sugars and things that clearly show that they don't have an eating disorder, if you know what I mean. But having said that, it could easily be that actually she is recovered and she's lost a bunch of weight because she's been on a kind of methamphetamine bender.
It's quite complex, yeah.
Yeah, and she's got it. And
she has IBS.
And she's got IBS, did you say?
Yeah.
Oh, yeah, well, so that's an interesting thing. So it's not uncommon that these symptoms will cluster together. And one of the big things that seems to be the case is that so eating disorders are really associated with what we'd call like an anxious avoidant personality. So they're the kind of people that will this is really generalizing now, but the kind of people who will say that everything's fine when it's clearly not fine, and they'll kind of grin and bear it, and they'll be often very anxious, often doctors and medical students, to be honest. So kind of being like, yeah, no, I'm going great, things are great, study's great, and actually they're like a anxious wreck inside. And they seem to unfortunately be more likely to develop eating disorders, and also these disorders like irritable bowel and that kind of thing. And so you could almost think about it, and some people do, as like kind of like the people are not acknowledging what's actually going on for them, so the body's kind of finding an outlet elsewhere. Again, that's really broad, but it's certainly something we see.
Yeah, that makes sense. Yeah.
And yeah, it's a whole thing going into personality, but yeah. But there are certain people that seem to be predisposed to these conditions through kind of how they engage in the world. And yeah, we're not very good. We're not the best for speaking up when we're actually having a terrible time. But you can be part of the change, guys. Mass change in medical culture. But yeah. Any other questions around that stuff? No. Okay. What's the time? 1:45. Well, look, if you guys got no other questions, then we could call it a day. Let you get on with your Monday. Yeah. If anything comes to you, you're welcome to me an email. Do you guys get sent a copy of the slides?
Yeah, these ones are on Moodle.
Are they definitely are they the same? Have you guys seen them? I don't care if you haven't, but because I'm just thinking I only just updated these slides, so I don't think they'll be quite.
These are on Moodle, I think. Yeah.
What's that, sorry? I don't think they can.
There's 4 slides on Moodle from.
Is it 4 slides? Okay. I mean, to be honest, what the other ones say, they only say it just lists drugs that you know. It says that, and it says that. But I'll update them anyway. Yeah, cool.
I also had a question, but it's not related to what we discussed today. I don't mind asking at the end if anyone else has questions.
Oh, yeah.
I'm so sorry. I just need to go and catch a bus, so I might have to run, but thank you very much.
No worries. Feel free to take off if you need, guys. Yep. What were you thinking, Ben?
It was something that Giles talked about in his intro lecture, which I didn't get to watch live. Because I had orientation and stuff, so I only got to watching it this weekend. But one of the things he mentioned with formulations, like writing formulations, is sort of following like a theory, like a social learning theory, or cognitive behavioral stuff, or that sort of thing. I didn't really understand how you could sort of do that in your formulation.
Yeah, sure. So what he's really talking about there is that there's basically a whole bunch of different theories that explain why people act in the ways they do, and why people experience what they do. And you can't really, some of them do have some evidence, but you can never really definitively prove that things are that way, and they're probably not that way, probably not exactly how the brain works. So they're all kind of approximations. But the theories don't, a lot of the theories are helpful, but they don't necessarily agree with each other. And so if you're going to do a formulation, you want it to have, you can bring in a few different kinds of, a few different models, but you don't want it to have a whole lot of different models. So the common ones that would be useful to look at would be, attachment's good, but it's tricky. So that kind of thing about personalities was attachment theory by Bowlby and then by Ainsworth. The other one is Erickson, is really good. It's quite accessible. And so Erickson talks about stage of life changes, so different kind of things that people are trying to achieve at different stages of their life. What else is useful? You can use it, like CBT is used in formulation. It's probably one of the more accessible ones. But I guess it's so I guess, say if I was going to use an attachment formulation for say a lady with eating disorder, I'd say something like, the kind of predisposing thing that maybe she's got some genetic stuff going on or whatever, and then I'd say that she's been I might hypothesize that, she seems to have developed this this anxious avoidant personality, and that's often associated with people not being able to safely express themselves when they're young. So if you think about it, like from the people that can't say that they're not okay often learn from a young age that it wasn't okay to say you're not okay. So maybe they're from a family where mental illness is frowned upon, or maybe their parents were violent and unstable and you didn't really want to piss them off, or maybe when they did mention it, they were laughed at, or they were, I don't know, the parents reacted badly, or so you kind of might talk about the past stuff a bit, about these are things that might have gone on here, and then talk about how kind of that links into what's happening at the moment, or maybe there's something that's precipitated that, but maybe talk about the fact that these symptoms may relate to distress that she's not able to kind of voice in a psychological way. Maybe she's not able to kind of experience it at all. It's a common thing we see is like alexithymia, where people won't be able to actually clearly tell you what's going on for them. So you kind of, I guess, and then you might say that, going forward, it'll be important that she does acknowledge the stress that she's going through and that kind of stuff. Or if you were going to do it like a CBT view, you might say that she's internalized these unhelpful core beliefs, and that she's kind of now acting in ways that are helpful. Okay. All good. Sorry. Yeah, all good. Do you have a script pad in the office? I might grab one. Oh, thank you. Sorry. Does that make sense? I know they're really kind of confusing. Like the problem with doing that is you kind of have to understand the model that you're going to use.
Yeah, that makes sense. And when you talked about the eating disorder patient with sort of anxious avoidant personality traits, that was actually quite, when I talked to her, and that was something that popped up in her history as well. Like her feelings and things being overlooked in the family, her feeling not heard, that sort of thing. So that definitely clicked, and that makes sense. Yeah.
So that'd be probably a useful one to work through, and you could say, you could probably say that, going forward, that if she's got these ingrained personality traits, that it's going to take kind of a bit of therapy.